next question will be a good discussion to have. So this is with regard to, let's say, in the setting of stage 3 ROS-1 positive lung cancer after chemotherapy, chemoradiation treatment is finished. What is the practice there in terms of, is there evidence for following with TKI? Do we think about immunotherapy like the durvalumab? Do we do surveillance? So that is a really good question, and it is a hot debate among oncologists right now as well. And I would say the bottom line is we really need more data to be published, specifically in oncogen-driven lung cancers and what to do with these different treatment options that are available. In surgically resected lung cancer with EGFR mutation, as many of you know, now the EGFR inhibitor osimertinib is approved to be used as adjuvant TKI following surgical resection. In ALK or ROS1 rearranged lung cancer, there are no approved indications for these ALK or ROS1 inhibitors to be used in the adjuvant setting, either after surgical resection or after definitive chemoradiation therapy. Whereas for patients who have no targetable gene alterations, the standard medication to follow the chemoradiation would be an immunotherapy drug called durvalumab per the PACIFIC trial. There is hesitation among oncologists to follow that practice for patients, for example, who are known to have ALK rearrangements or ROS1 rearrangements, because if you extrapolate from the metastatic setting, we think the immune checkpoint inhibitors are less likely to be beneficial in that context. And so then if we are leaning away from using an immune checkpoint inhibitor like durvalumab in patients after chemoradiation for ALK and ROS1 rearrangements, then do we just surveillance with 6 scans and use the TKI once, and if there is evidence of metastatic disease progression, or do we use it earlier? What's your practice, Dr. Kim?
I have not encountered exact same clinical scenario thus far. I had patients who had the chemoradiation, then was found to have EGFR. Then I had long discussion with the patient, going over the data. As you mentioned, Dr. Lin, the data of immunotherapy in the EGFR positive setting, where you don't see a lot of response in the setting. So does it make sense to go ahead and give durvalumab with the EGFR ALK or even ROS1? This suggestion about beginning entrectinib, in my opinion, is not unreasonable, but I think we really need more data, at least from the real sort of world data, to suggest what we need to, what we can do. There is some suggestion, at least in the retrospective data multi-center study published recently in one of the journals, showing if you use EGFR TKI after chemoradiation in the setting of EGFR mutant non-small cell lung cancer, the outcomes were looking better than the patient received the durvalumab, but that was retrospective, not randomized. The level of evidence is not really great, one or high. But in the absence of good data, this is a reasonable consideration, though we are lacking really sort of solid data to guide us at this point.
Thank you, Dr. Kim.